We are
You
live.
want to admit the person there who's trying to come in? Okay. So are we ready, Kekasha?
Yes,
Kekasha,
Peter,
are we
we are
live?
live now. Yeah, we are live.
Okay, thank you. Thank you. Well, once again, it is a pleasure to be here. I think this is our sixth or seventh meeting. I can't remember exactly what it is, but we have a lot of exciting presentations and discussions we're going to be coming up starting on July 24th. And we will be announcing all of the new podcast sessions we'll be having sometime during the next week. And there'll be sessions up through September, probably into October. The next one is on July 24th. It's on long COVID and breathing, which will be very interesting because we have a long COVID person who's suffered immensely who will be here. In fact, Lisa, who we're going to be talking to with today, actually worked with this person who will be showing up on the 24th. You'll hear much more about it, of course, when we do this session, but it'll be very interesting. And we have others, like we have one on breathing and dentistry coming up in August, and we have one in breathing and education, and so on. So we have a lot of interesting things down the road here. But today, it's only Lisa and myself here. There were some medical considerations here that it blocked Wolf Fellner, which is our usual co-host, from being here. He couldn't be here today. And Sandra Raymer, my partner, my life partner, as well as my business partner and educational partner and professional partner, she's not going to be here today either. So it's Lisa and myself, and that's it's very special for me to be able to be here with just Lisa and nobody else. Lisa and I have been very close friends, and we've been involved in all kinds of projects together. Everything from different programs that we offer in the Professional School of Behavioral Health Sciences, where she is a faculty member and an administrator as well. She earned her master's degree in breathing science with us sometime quite a long time ago, one of our very first graduates. And she's been a major success in what she's doing. And I think we're going to learn something about that today and about how that came about, how she became such a success and what made the difference and what she learned that brought her to where she is now. She has a very successful business, a very successful enterprise in Canada. And as I say, she's very closely connected with the school, as well as with the company known as Better Physiology that actually manufactures capnometers. Better Physiology has a whole new capnometer now that you wear on your ears like a headset. It's a whole new kind of technology I'm not going to describe here, of course, but she's very involved in our company, in the capnography company as well. She has a business called Conspire Health in Canada. And this has evolved over a period of years into a very special place that I want you to hear about. And so we're going to ask her to talk about how she got to where she is, about the business itself and how it operates and who her audience is. And we're going to ask her questions about that. And we're going to have kind of a conversation about that. But we're going to start off with kind of a mini presentation on her part to really let us know, to kind of give us an overview of all of this. And then I will start to ask her some questions and so on to go into greater depth in the various things that she might bring to the table, including a case or two or whatever she decides to do. So Lisa, why don't you start off and describe to us how you got to where you are and what your business does?
Great. Thank you for that introduction, Peter. And we know there could be rabbit trails. So we will try, just keep bringing us back to the structure of talking about the business and how it delivers opportunities for people for recovery. And one of the biggest pieces that, if I'm looking at my trajectory from the beginning, what brought me to this business was previously 20 plus years of working in mental health services and working to fill the gaps where where my clients and my residents. I ran an in-home recovery center for women with chronic mental illness. And I would study and take anything that I needed to meet the gaps that the programs and the medical community couldn't fit for them, couldn't fill those gaps, looking for the next step that was required to come into their recovery. And as a part of that journey, and as well as a physical health journey of my own, where I was in a profound car accident. I hit 2 deer on a highway while passing a truck. So we know I wasn't going slow and I didn't have anywhere to go. So a year and a half after rehabilitation, my insurance company said, we're putting you on permanent disability. And that's not how I roll. I really thought that I was doing everything that I had been asked to do. I should have had good results. I wanted to find out what the barriers were. And that's how my world got turned into breathing sciences, because it was the underlying mechanisms that were controlling my body's ability to completely recover. The underlying mechanisms of breathing behaviors that had gone completely unnoticed, likely from childhood, and then built upon with this traumatic head injury that I had. So when I got to the place of understanding that it was more than a trauma response, that there was something fundamentally, physiologically changing in me, that was exciting, because then that meant it was actionable. So when I was in some other courses about breath work, trying to figure it out, I had one particular mentor who would love to talk about the science, and then I'd ask questions and I just wasn't getting where I wanted to go. And so he finally handed me a paper by Dr. Peter Litchfield, and I read it and went, oh, this is what I'm looking for. That's really the beginning of the big changes in my life and in my career, was working with the capnometer on my own, getting the training and recognizing that I could recover. And not only did I recover fully within just a few months, but I also exceeded in many other ways in changing how I saw the world. And some residual health issues that I'd had since childhood were gone, because I acknowledged, found what was going on in my breathing, and was able to make a meaningful substitution for how I was responding in certain situations that decoupled my breathing from safety, emotional control, etc. So even pain control. So that's how I got started. And as with everything in my life, as my father used to say, anything worth doing is worth being obsessive about. So here I am, many years later, doing this full time, finishing the master's degree program, becoming a registered mental health professional as a psychotherapist in Canada, and the first one that was recognized and given full licensure with breathing sciences as my platform. So I can bring in a lot of other psychotherapeutic modalities, but whatever I'm working with, it's breath first. And that brings me to my practice at Conspire Health, where everything we do is working together to bring alignment to the breathing, and then watch how the physiology responds. And once the physiology is back into that reflexive respiration, we see amazing recovery in people whose problems weren't that their body couldn't heal, it's that there were too many obstacles. So Conspire Health has been, I went through a few names, but that we've been settled on that for a few years now. And we're working in a clinic near the university in Saskatoon, Saskatchewan. It's 50% of my clients are online clients, and 50% come to see me in person. I work with basically anyone who's breathing, but specifically people who've had long-term illness or disabilities in learning, to look at what's underlying with the breathing. Is there a connection? And if so, can we make a change? And So by its nature, I'm usually working with people for quite a while because complex cases are my specialty. So from there, what else would you like to know today, Peter? When I bring people in, we do a really in-depth assessment of their breathing habits, what kinds of symptoms are coming up for them. And in the process of a discussion and working with biofeedback from the capnometer, we can glean other information about what's happening. And it's really an educational assessment more than a doctoral, medical, clinical, I'm just taking notes assessment. It's a give and take. We're discussing what's going on, exploring the symptoms, and then even trying to work with the breathing to see if allowing the breath to be a little bit different changes the symptoms, either to the positive or the negative. Does it reduce symptoms? Does it increase them? And it's very eye-opening for clients to recognize that there is something they can do. This is actionable intel on day one. And so people go home knowing that they have more power than they thought they had, that it's not their fault that they're still sick, and that there's a way out.
Well, I know that pregnancy is one of your specialties, and we did one podcast on pregnancy that a number of us did. You weren't, unfortunately, you weren't available, and we did it ourselves. And of course, I've been closely working with you on the subject of pregnancy and breathing for a long time, so I did a lot of that. But I'm not the one with the experience. I mean, I have not worked with pregnant women. I'm good at the conceptual part and explaining how breathing and respiration are such an important part of how women experience pregnancy, and the breathing habits they learn as a function of having been pregnant that they carry forward in their lives. So I'm good at that, but I'm not experienced in doing the work. So I thought maybe one thing we could do is you could present or describe a case, of a client who was pregnant, who you worked with, who may have had to address certain issues they didn't understand, where breathing was somehow an important part of that. So whatever you might want to present or describe to us, we'd be really all ears.
It's such a big question and field. Having worked previously through the mental health services and maternal health services that I was offering before I came to breathing, I was lucky enough and privileged enough to attend close to 1,000 births. And during that time in support, really learned so much about how the breath and how a woman was processing her pain was changing labor and changing birth circumstances, but didn't have the education to understand the why. So when I come into this now, and I'm working with anyone in their childbearing years, it's important to know that we come into our childbearing years with the breathing behaviors we learned when we started menstruating. That's when women start to make different changes subconsciously while they're in adolescence. If they have had experiences of safety with their breathing, going through adolescence usually doesn't necessarily disturb the baseline breathing. But because of the progesterone that increases during the luteal phase and that increased respiratory drive that we all experience if we're menstruating, if fast breathing is scary to us, we take it over. We take bigger breaths. It feels weird that we're breathing fast. And if it's fast and shallow, as the metabolic system needs during that time, we might be misinterpreting that as bad breathing and taking it over. And that in itself lowers the CO2 levels and creates what most of us call premenstrual syndrome. And that's the irony, is that almost every premenstrual symptom is a hypocapnic symptom. And if we allow the breathing with that increased ventilatory drive in the luteal phase, those symptoms go away, right? Because now the reflexive Yeah, the reflexes of our respiratory system are meeting the need of the uterus to build the lining and then to shed it if necessary. So with that in place, that's where I start with anybody in the childbearing years is, how was your adolescence? What was the change like for you? Because we're looking for, are there any previous breathing behaviors that are going to affect the gestation and pregnancy?
Let me just say one thing here, because it's so important what you're talking about. Because you see, there's a very significant correlation between CO2 deficit, hypocapnia, and people who are going through their menstrual cycles. Okay, not even talking about pregnancy. And so a lot of people, when they see the person breathing, and they're breathing in a shallow way and they're breathing rapidly, they're assuming that the hypocapnia is the result of going through the menstrual cycle, that that's what's causing it, that the chemistry, that the fact that you're going through that's what's responsible for the overbreathing. Now, that doesn't make any sense. It makes no sense whatsoever. That someone who's going through a menstrual cycle, that women who go through menstrual cycles hundreds of times in their life, that they end up compromising their respiration, that's the way the system was built? No, it's not. This is a correlation. This isn't cause and effect. What happens during that period is the way that she just described, where the respiratory drive goes up. So you're breathing more rapidly, but you're breathing shallow. Why are you breathing shallow? You have to breathe shallow if you're breathing fast. If you're going to keep your CO2 level where it needs to be, and you're breathing fast, you've got to take very small breaths. And that's what happens. You take very small breaths, you breathe fast, and the CO2 level can be completely normal.
Exactly.
So you look at a certain percentage of people going through a menstrual cycle, a certain percentage of them are overbreathing, but a lot of them are not. And if it was really because of the chemistry of it, they'd all be overbreathing. Every single one of them would be overbreathing, but they're not. It's only certain ones. Who are they? She did a beautiful description just now of who they are. People who interpret, they experience the breathing. We call this a type 2 habit. They experience the breathing, and that experience creates an emotion, not because that's the way it is, but because they learned that emotion. They learned to be emotional to the symptom. They learned to function cognitively differently, to interpret it and say, this is not good. So the emotional and the cognitive behaviors, which are all learned in respect to that symptom, then mediate a change in breathing that brings on the symptoms associated with a menstrual period. This is what we call a breathing behavior analysis. That's what she does. She does breathing behavior analysis. Now, she was going to lead us into pregnancy because that's a much bigger step. It's going through a menstrual cycle is one thing, but becoming pregnant is another, where you see most women who are pregnant are hypocapnic, but not all of them. So if you say it's because of the hormone, I guess there's a certain percentage of them where the hormone doesn't work. It's something that people learn as a function of their situation. And when we can understand that, we can do a lot more to help ourselves and help other people. When we understand how the programming of physiology takes place. That's what's the most interesting thing about physiology is that it's programmable. That's what makes it alive. It's programmable. That means you learn, not just you, every cell in your body. They're all programmed, and they're programming themselves all the time. In psychology or in behavioral science, we call that learning. So she's talking about the menstrual cycle and how it will create compromised respiration where you lose CO2 and get all these symptoms that you associate with a menstrual period, when in fact, a lot of this isn't a function of the chemistry as much as it is a function of what the person has learned in response to the experience of the symptom. That was a long interruption. I apologize. Go ahead.
That was a great reframe and reflect back. Thank you, Peter. That's great. So that's exactly what we're talking about. And when we start with that history, because our breathing always has a history, however we're breathing right now is exactly how our breath has been serving us. We've made decisions about our state and what we access during different situations. And so I don't ever come into this negating someone's breathing. You don't have bad breathing. You have breathing that has adapted. And if it stayed adapted, it was because it was serving you in some way. Now, if those symptoms are heightening and it's not serving you now, and you'd like to unravel that, we can do it. We can do it by changing our response to certain stimulus, or as some people like to say, triggers. And I'm careful with that word because sometimes it gets attached to trauma right away. And there are times when triggers are trauma. And there are a lot of times where triggers are learning. It's when we make a decision about how we're going to respond. So when I'm working with women in the childbearing years, even before they're pregnant, this is where we start. And I have a number of clientele who come to me with fertility issues, who've had premenstrual syndromes that are very profound. And it turns up in their history that they had breathing habit disorders prior to adolescence. And then adolescence compounded that with an additional response during the luteal phase to the changing in the body chemistry. And then when they try to get pregnant years and years later, they've been working with a reproductive system that has never been getting everything it needs because the body's prioritizing oxygen delivery to the systems and organs that keep us alive. Reproduction is not
really
necessary to stay alive.
This is really interesting, you see. To me, breathing is interesting. And it's a lot more interesting than just say, oh, gee, my breathing is shallow, I better breathe differently. And then you practice doing something different and you don't address the issue at all. You don't understand that you've learned something and you need to cope with that, discover what it is and modify it. Instead, you just come into the situation with some kind of intervention, which may exacerbate, what you're already doing, make it worse because you don't really understand what the hell's going on. And breathing is so much more interesting when you understand it as a psychophysiological enterprise. It's not just something physical that you manipulate in the name of making it right somehow, and you don't even know what's right. Somehow you have this idea that this is right. Why is that right? Why is that good that what you're doing? You're breathing this way or that way. What is it actually doing? How does it bear on the question of respiration at all? What does it have to do with respiration? It may just be a ritual that helps you relax or something like that, but really isn't anything to do with the foundation, the physiological foundation, and how respiration is actually compromised in mediating symptoms. Anyway.
Yes, and I'm really glad that you went to the ritual piece because anyone who menstruates knows there's an entire lineage, a social context and belief system around the burden we carry because we menstruate, that this is necessary pain, that we try to navigate what the experiences are and explain them away as, this is just part of being able to bear children and extend the lineage of humanity. So we become mini martyrs by learning how to befriend our suffering. Well, what if that suffering is completely unavoidable? It's completely avoidable. It's not meant to be there. Our physiology doesn't want suffering. It wants efficiency and comfort. So when we recognize that there are responses that are taking us away from efficiency and comfort, and we make the shift from detaching the parts of the breathing that we've accidentally taken over, right? Then we can experience ourselves as we actually are, instead of as a result of our breathing choices. And that's really the eye opener for most people when they come in, is like, wow, it's not just I don't have pain anymore when I'm menstruating. It's I feel so much more myself. I'm getting to know myself differently. Wow, I have energy that I didn't even know I could have, and I'm not working out. I'm not doing anything different. Or even feeling a new sense of identity where they feel more safe in their body and more safe to explore in the world. That's starting to sound metaphysical, but it's about cognition and choices. Right? So as we move through, whether a person comes to me when they're young or in the fertility years where they're having trouble getting pregnant, and we are able to make a healthier environment for a uterus to work properly, right? And then we continue to work through the pregnancy, whereas where I often see people, like in a perfect world, I would see everybody when they're younger before they want to have children. But when we get into gestation, most of the time when people come in, their CO2 levels are moderately to severely chronically low. It's not just in 1 or 2 situations, it's all day, every day. And they're not sure why it's there, right? So then we have some unpacking work to do to create a new awareness. And that's where everything starts, is creating enough awareness around breathing behaviors and learning about respiration and how those two things are different, so that they can interact with those systems more intelligently. And that takes time. And we have to build trust with the client and with the client in their own body, right? So it takes, I usually see people once a week during pregnancy. And during that time, we're creating that awareness. We are watching our breathing, not just on the screen, but learning how to really be with ourselves without taking it over, which is really a masterful stroke, because, you know, most longtime meditators and Buddhist monks talk about being able to watch the breathing as the culmination of years and years of practice, because we have 2 different brain parts working at the same time, that at the moment we observe our breathing, we're likely to change it. So cultivating that awareness is a big piece.
It's a very, these are some very important points that you're bringing up. And one of them is the matter of trust, and another one is a matter of observation. And they go together, actually. If you don't trust, you don't observe, you manipulate. When you trust, you allow and you observe. So, you know, they go together. And one of the things that's very interesting, you can try this yourself, the people out there, where you might be working with someone around their breathing and you want them to say, focus on their exhale, okay, and to watch the breath go out, to observe it, to observe the breath going out, observe how the body stops for a moment, and then there's an inhale that comes in, and there's a reflex that's located between the end of that breath and the inhale, that there is a time frame there, that when the reflex kicks in, you can learn to experience it, to find it, to locate it. And when you locate it, you know what you find? Hunger, air hunger. You find that you want to take a breath. You find that your body, there's a psychological aspect of this physicality, this inhale reflex. There's a psychology associated with it. What is it? I feel like I need air. So it's normal to feel that. If you feel air at the end of a breath, so you suddenly feel like you need to take a breath, you have air hunger, that's the way, that's what it's about. Now, what's interesting is that when you do this and you ask people to do this, I find this invariably, that probably 75% of the people, when I ask them afterwards what they observed, they don't tell me anything about what they observed. You know what they tell me? They tell me what they did. I did this, I did that. I said, I thought you were going to observe what your body was doing. You were going to observe the exhale. You're not describing an observation. You're telling me what you did. And so for a lot of people, when they focus on breathing, it's about doing something. It's about doing it the right way. Or it's doing, it's like implementing something that you know about. And that's precisely the antithesis of observation. So learning to observe the breath is fundamental. And it's a metaphor for self-observation in general. Okay, and so then when you can allow it, to observe it, you're allowing it. You're not interfering. You're the third party. What is my body doing? And why is my body doing it? That is, it's not just reflexes that are operating. The body learns. It has habits of its own. Most of our habits were not learned. Most of my habits were not learned by me, by Peter. They were learned by my body. And I can become a victim of what my body has learned. How and why does the body learn what it does is what my whole profession has been about since I earned my PhD and left my graduate studies in 1970 to become a professor of psychology. And that was my whole thing was, how does the body do this? So there's a lot to learn from your body and what it's learned and how it's affecting you and how you can interact with your body so you can assist your body in learning something different. So just allowing it is great to allow those reflexes, but there's also all the learning that your body has accomplished that you need to become aware of so you can work with your body to learn something different. I mean, that's the most exciting thing about physiology is that it learns. But just recently, this is amazing to me, just a couple nights ago, I'm reading this book we recommended to my partner and myself called The Light Eaters. Light, light coming from the sun. Light eaters, not eating a little bit of food. It's eating light. And guess what they are? Plants. What I had forgotten, I never thought about it, is plant physiology really is no different than, it's different, but it's physiology like animal physiology. And I talk about the psychophysiology of the body and that life is psychophysiological, that survival in and of itself is a psychological kind of motivation. And it suddenly dawned on me that plants are not an exception to this. And that really blew my mind. My God, plants, maybe they're psychophysiological as well. Why not? I mean, they are physiological. Just because they're plants, they're not psychophysiological. It was a big kind of awakening for me just a few days ago. I said, my God, plants, And I remember that there were studies done years ago, like the Venus flytrap that learns to do all kinds of things to capture beetles and things like that. And I'd kind of forgotten all about that. But I've just started this book. We're reading it out loud. We've read about 12% of it. Quite interesting.
That sounds fun.
Yeah.
That sounds fun. And as someone who I have a really great relationship with the plants in my house. And the fastest way to teach a plant something is to give it a hard pruning. Why? Because you've told it that is not the way to grow. You must find another way to grow. Right? And life is like that.
It's really interesting. And then you can get into respiration with plants.
Yes.
Just because they don't have lungs, it doesn't mean that there's not some kind of gas exchange. Obviously, plants are very involved in gases, oxygen and carbon dioxide. Yeah. So respiration applies to them, but it's a very different kind of a process. So we got kind of a little bit astray, but that really excited me.
When there would be rabbit trails. This is one of them.
Right. This is one
good. But I want to bring it back to
observation.
One of my favorite ways right now to play with breath to help people become more aware is what I call the breathe like me game. And in the breathe like me game, we suspend the need to manipulate the breathing while the person watches their own breathing for the purpose of teaching me how to breathe the way they breathe, so I can experience the world the way they experience the world. And I give them time to watch their breathing and make notes about what their breathing's like. And then we make notes about when it gets kind of weird and they take it over. So they can see how they interrupt the pattern of what they're like when they're not thinking about it. And then they have to fumble around and find the words and move their bodies and demonstrate to me and teach me how to breathe like them. And the metaphors they choose and the way that they move their body to explain it. And then they watch me breathe like them until they think that it's a good representation. And then they have that awareness. And now I have an awareness of what they might be experiencing by the breathing habits that they have silently. right? By the way that they're showing me that they breathe.
There's no better way to learn than to try to teach something.
That's right. So
That's what
I
I
play
discovered.
breathe with me with all my new clients, and breathe like me. Sorry, not breathe with me. Breathe like me. And oftentimes that ability to set aside what they think good breathing should be is a barrier, and we have to do it a few times. But that's some of the arc, right? Now I can do that with all of my clients, but when I'm doing it with women in pregnancy, we're breathing like two of them, right? Breathe like me. Breathe like me when I'm pregnant. And then they have to show me how things have changed. What do they feel? Where are their uncomfortable spots? Where do they feel restriction? What feels like it's too much or too little? What kinds of breaths feel stressful since they've been pregnant?
And that's so important. It's what they feel.
And that's really
about
helping
this kind of work. To focus on what people feel when you're doing breathing work is fundamental to doing the work. What do they think? What do they feel? When does the feeling change? How do they interpret that feeling, and so on? It's very, psychological in the breathing that you do and I do, and a lot of us. It's not a manipulation that you bring into the situation to accomplish, say, relaxation or something. It's a part of who you are, just like my posture is, and the way I talk, and so on. It's an element of my personality. It's an element of how I cope, and so on, to get to know myself from a breathing respiratory perspective. And then we talk about it. A lot of people find it very difficult to talk about breathing. They don't want to talk about it. We've seen this all the time. Lisa and I, and others who do breathing behavior analysis. It's very difficult for them to talk about breathing because they feel when they talk about it, they start to manipulate it and it's all going to go wrong. They just assume avoid it. I've mentioned this before in some of the other podcasts, so I won't go further into it. But it's such an important thing. And I think that when breathing comes into your attention, like when you're pregnant, then you're forced to really focus on it because you're struggling with it. So what do you do when you're struggling with it? That's the question. And what some people do is it's really self-defeating, self-destructive. And what other people do is very helpful. It all depends on the person and how they're involved with it, and their ability to observe, their ability to learn from what they're doing while they're pregnant. Anyway, do you have a case or something maybe you could describe? Or I know that cases are something that are private. You can't just jump in and describe someone without their agreement, but you can talk about it in general terms or something like that. Is there anything you could talk to us about in terms of personal experience?
Yes, absolutely. On the way into that, I want to make a couple of more comments as I go into a specific case of recognizing that in obstetrics, it is considered normal for a woman to be hypocapnic. In all the textbooks, they say a sign of being pregnant is being hypocapnic. And then if you keep reading in the research, it says, 80% of all pregnant women are hypocapnic. Well, why aren't the other 20%? How come they have normal breathing while the others don't? So this brings us back to what I was talking about. What did we learn in puberty, and how does that move forward in addition to anything else that we've learned about our breathing? And so we know right off that hypocapnia is, while it's typical in pregnancy.
Yeah, CO2 deficit, hypocapnia.
Right.
So make sure everybody knows.
Yeah, a CO2 deficit in pregnancy is typical, but it's not physiologically normal. It's like
necessary.
Or necessary.
It's not a necessary outcome at all.
Exactly. It's being in the longest luteal phase you can possibly imagine. Pregnancy is an extended luteal phase because there's no menstruation. Instead, the body has to kick up metabolic system to continually feed and support the needs of the uterus and the fetus growing within it. So that metabolic need doesn't stop. It's like walking uphill 25 hours a day, 24, and then it feels like 5 during the day for the entire length of gestation.
Could I mention one thing here about what those statistics for a second? Is that I have seen in the literature the medical literature, they're trying to explain, hypocapnia, to try to find some reason why it's good, because all these women are hypocapnic, and they're only looking at it as a plumbing system. Well, it's there, it's there for a reason. And so this is a good thing that the CO2 level is low. Trying to find an explanation for why it must be good without understanding how these are programmable things, without recognizing the programmability of the physiology. I can't tell you how many people, for example, have had dental surgery, for example, to widen their airways, because all the symptoms they're experiencing, it was all about, in essence, people not being able to get enough air. So if we widen the airways, then they'll get more air and they won't have these symptoms like breathlessness. I can't tell you how many surgeries have been done on that basis. And you know what the outcome of those surgeries has been? Zero. They have all the symptoms still. Why? Because it doesn't have anything to do with the width of those airways. It has to do with learned behavior, maybe based on those airways or something else.
Yes.
So again, it's this lack of attention to what life is, a self-programmable system, psychologically driven. So you end up in these places like, I just talked to a dentist 2 days ago, extensive surgery, complete modification of the face and the jaw and everything, because the person couldn't get enough air. And when they were done, the results were zero. They never looked at the programming. Let's just do the surgery.
Right.
Okay?
You know what I find when I work with people?
It's outrageous. It's amazing.
Yeah.
And you ask the question, how could this be missed? People always ask me, why don't people know about this, Dr. Litchfield? If it's really true, why doesn't everyone know about this?
Right.
The reason they don't know about it is because of the way they think.
Mm-hmm.
They think about things in a certain way, so they don't see what's going on. They don't see it. They aren't taught it. They don't know about it. We're all like that, of course.
Yeah.
No exception. It's
No.
just that in the case of breathing, I am an exception, But it is. I have 2 chapters with my partner Sandra in a airway medicine book coming out this year. It's supposed to be the airway textbook, and
Right.
we have 2 chapters on how, in essence, looking at breathing as behavior takes you to a very different place when you just think of it as some kind of reflex. It is so much more of that. There's the reflex in it that's a foundation of what respiration is about. But breathing is mechanical. It's something that you learn. It's a behavior. It's a behavior. That simple word, looking at it as behavior, changes everything. Changes everything. Anyway, go ahead, Lisa.
Well,
this is sponsor day, everybody. This is sponsorship day. And
I'm
so
glad
she's a
you
sponsor. Conspire Health is a sponsor of this, our nonprofit. So we want her to benefit from this in her business. I mean,
So
we
I'm
want
gonna
to
make
help
an
her
arc.
do what she's doing.
I'm going to do an arc from what you just said back into the pregnancy cases. So when we're looking at sleep disordered breathing and airway specialties, this is part of what I see all the time in the work that I do with Dr. Anil Rama and his sleep specialty clinic at sleepandbrain.com. So when I'm working with people there, often what we find is that they're coming to me and to Sleep and Brain after they've had surgeries, and they can't figure out why they still feel exactly the same. And what's often happened is they're breathing like they have their old airway. They had, for some of them, complete blockages in their sinuses. And now they have open sinuses, but they're still breathing like they can't get air to move through their nose. They're over efforting. There's so much strain in the idea of allowing a breath that
and the habit
they are
doesn't just
creating
disappear.
the exact same symptoms that they had before the surgeries.
Well, the habit doesn't go away. The habit is still there. That's the point. If you don't understand it as behavior and you don't dissect it from the standpoint of breathing behavior analysis, you don't address it. The
And it
habits
goes
just don't
both
go away
directions.
because you change the airway. The habit is still there. That's the way habits are. They're supposed to be like that. They're physiological and they're lifelong. They stay with you for your life or they'd be useless. So when they're negative, they stay with you for your whole life too, unless you address the elements that make it up. So the surgery doesn't address the elements, it just sidesteps the issue. Anyway, go ahead.
I
Yeah.
see that a lot with parents that come in with children who are sick all the time or are having sleep disturbances or are having behavior issues in school in their first 3 years. And then I hear from them that, you know, as a child, they constantly had sniffles, they were mouth breathing while they were sleeping, they had their tonsils out, and everything is worse, not better, after they've had these surgeries. And when I spend time with the child, and we do it more like play therapy, which I think we should do for all ages, but it's easier with kids. We just get on the floor and we play, and they don't know that I'm watching their breathing. And we can see that even after surgeries where they've taken out really overgrown tonsils and inflammations and sometimes also adenoids, they're still breathing as though they have those swollen pieces in their throat. And then it perpetuates and continues to bring on the symptoms that they had previously.
And there's
So
the metaphor of it.
right.
There's
So then
a
when I
metaphor
teach
of it.
them how much room they have now since those, I said, remember when those used to hurt so much and you could feel it, and every time you would have to breathe in, you would kind of make a squishy face because you knew it was going to hurt. Yeah, they agree with me. Yes, yes. But now it's not like that. What if you can let it go in, just like when you take a glass of water and it won't hurt? And so that becomes the beginning of their awareness. And now we breathe with the airway we have instead of the pain we are used to. And I can apply that all the way through. And back to pregnancy, why do so many women in pregnancy experience sleep apnea in the third trimester? Because of this baseline breathing behavior that's bringing them into a chronic hypocapnia. That what happens is, if we have hypocapnia all day, low CO2 all day, that means our muscles are not getting what they need, because what our body has for oxygen delivery and good respiration is removing it. Is replacing it into just the organs that need it. So when we go to sleep in pregnancy and we're hypocapnic, we have low tone in our throat. The muscle can't hold its position. The tongue can't stay where it's supposed to be. It's like sleeping when you're drunk and everything collapses. And so women in second and third trimester who are experiencing that sleep disturbance are having experiences of apneas and hypercapnic responses that create anxiety responses. Now they have disturbed breathing, disturbed nervous system, and they're exhausted because they think they're pregnant. This is just how
What's
it is.
important here is there's a pattern.
There's a pattern.
And it fits into a context. And
That's
all
right.
learning fits into a context. And in the largest sense, it can become part of personality. It can become part of your social life. It can be embedded in all these different parts of your life. And unless you do a breathing behavior analysis, you're not going to discover how it integrates with these other things and how it serves as a link between all these very interesting and important things. And there's a metaphor. One thing people forget a lot, unless you're talking about psychological things, people don't think of it, and that is metaphor. That you may learn something in pregnancy because there's a struggle and you learn to breathe a certain way. And now when you find other struggles in your life that aren't pregnancy, maybe it's a social struggle you're having with a spouse or something. And now it produces the same behavior. And it generalizes. It generalizes by virtue of its being a metaphor. I mean, if you look at just the physiology, you're never going to think of that. You're never going to understand what the hell is going on. The metaphor is the psychological thing, and it will mediate where those responses, those breathing responses will show up. You simply cannot understand breathing unless you look at it psychophysiologically. You won't.
That's
You'll
right.
never get it. The pattern and how it plays such an important role in our lives. You won't get it. So anyway,
So some of the cases that
go
I've
ahead.
are women who are coming in early in their pregnancy and they're really feeling those first trimester symptoms, the fatigue, the nausea, the instability with their food. And sometimes it's brain fog. You know, in the birth community, they always call that placenta brain, which is funny, but not funny. And why is it placenta brain? Because the low-lying but chronic hypocapnia that a lot of pregnant women find themselves in is creating these dysfunctions in normal, healthy systems. And so we have this disordered breathing creating so many symptoms. And when I work with them, after we've gone through the awareness process, then when they can see more about how they're working with the breath, then I turn it into learning all the parts of the breath, learning all the ways we could control something so that ultimately we don't have to. That ultimately we can trust what the body's doing. If we notice that the breath is a little faster, oh yeah, I'm good at that. I know I get what I need when I'm breathing fast. Oh, my breaths are really like fast and hard today, really big breaths. Oh, but I know I know what this body's doing. I can feel that I'm in a normal CO2 state, so I don't have to worry about it. So we enter into this exploratory phase where we learn all the ways we can interrupt the breathing. And we do it in little stages. We work with the inhale. How does the inhale feel to you? How does the inhale feel if you do it just a little sharper in the first second? Does it change anything? What does it feel like if you create a little tension in your neck halfway through your inhale? Now, I'm working with what you're seeing in the client, so it's a little bit different with each person because I'm working with what they're presenting with. And this is why there's no cookie cutter approach, because I have to work with the exact habits that are presenting for each person. And even though we might do a similar learning exploration, like, okay, let's see what happens when we breathe in for as long as we can. How does that feel for you? Right? We're going to get very different responses based on the underlying, not just the underlying breathing habits, but the breathing habits stimulus. What's the trigger? What are they getting out of that? What have they learned that keeps them in that loop? And so I love doing this with groups because we'll do the same interaction and then I get people's feedback and we have 10 different responses to one breathing intervention. And that really hits home, especially in groups of pregnant women, that we've all experienced the world differently. We've made different decisions and different judgments about what breathing feels like. And now we have to bring it, they're all have the same goal, which is to bring it back to the reflexes. So as we're going through, there's no one way to have good breathing. We have to explore where we are and then learn to let go. So as normally, by the time, if I get to work with someone in their first trimester, by the time we're at 20 weeks, their CO2 levels are back up to around 35 millimeters of mercury.
Which is normal.
Which is
normal. Because, you know, people out there probably don't relate to the number.
The body can't compensate very well under 35. You're going to see a lot of symptoms. Over 35 and up to 40, the body's really being efficient. And if it does need some support, it has backup plans like the kidneys. So these are science pieces that we won't have to get into today because then it would be a 3-hour call. But as I work through it, we go through each of these things pretty methodically. So I'm working with them to acknowledge tone in their breath. How does tone affect the way that they're breathing? Do they notice differences between when they're really tight and really soft in their throat? How does the breath feel differently? We'll move on to creating more awareness and self-exploration through these mini interventions. Through diaphragmatic exploration, through thoracic exploration, looking at the transitions between breaths and how do they prepare for them? What's the psychological meaning of a breath hold? Learning how they personally are interacting with that. We move through all of the parts. I kind of have it broken down into 9 pieces, but it's not as I've said before, it isn't breathe this way and everything's fine. It's not a technique that makes everything better. It's an exploratory process that helps people learn what they need to let go of, what they need to unlearn. And then we can apply new responses to those triggers.
You should,
For example, what's that?
No,
For
go ahead.
example, if we have someone during pregnancy who's really noticing that the anxiety gets really high on days when the baby is high in the fundus and pushing a lot on the lower ribs, and they're just constantly pushing the baby down saying, I can't get enough air. I just can't. These are opportunities to teach them and to remind them that our breathing mechanics are incredibly resilient and flexible, and that when the baby's up front under the diaphragm, we can allow the back body to open up and breathe for us, and we get everything we need. Acquainting people with their mechanics through the lens of good chemistry is the only way to do it, I think, ethically. It has to be done that way. Otherwise, we're teaching breathing mechanics that are probably dysregulating people, or could be dysregulating people based on their baseline chemistry. So we work on, in the prenatal classes, we work on all the ways we can have access to different parts of our breathing mechanics while maintaining good chemistry, and learning how, when you go down to tie your shoe, previously you go down to tie your shoe, you start breathing in the chest, it feels hard, or you start holding your breath and getting irritated, when you can allow it to be small but slower, and your back opens up. When we let go of trying to control the breath when we go tie our shoe, and we allow the breath to come into our back, we have perfect respiration, right? Same thing for moms that are carrying a toddler on one side and they're 8 months pregnant and they're grocery shopping. Yeah, there's a reason why you're feeling dizzy in Safeway or the store while you're pushing the cart, because you're hurrying to get out of there. You have strain of the weight, and your breath is now moving more air than you need. You're overbreathing, right? So is it that it's too much now? You can't grocery shop now? No, it's that the mechanics and the chemistry are out of alignment. So I spent a lot of time in pregnancy helping women reacquaint themselves with their mechanics in an easeful way. And that translates into very different labor experiences. So when they're in labor, imagine the concept of ease in labor. So when we see other small mammals going through birth, they don't have doulas, they don't have midwives. They lay down, they breathe slow, they're panting, but they're not breathing fast, right? The inhale is soft and easy. They're not moving a lot of air, but they're breathing often. And when we do that, when the uterus is moving, it's not contracting as we go through the birth process, it's retracting. It's a stretch. We have, because of years and years of misinformation, we frame that as, oh, I'm getting contractions. Well, the only thing that's contracting is the very top part of the fundus of the uterus. Everything else is stretching backwards. So if you can learn to have normal breathing chemistry while you do a stretch, you can reduce discomfort during labor to almost nothing. It's intense. Your body's working, but it doesn't have to be painful. It doesn't have to be painful. And again, we talk about this in some circles, especially in the birthing communities, where people talk about, painless birthing, almost like it's a metaphysical phenomenon, when really it's about how can we learn to allow the body to do exactly what it knows how to do without taking over our own physiology. So I've seen multiple women who've had previous births with long failure to progress episodes because there was so much tension that they couldn't let go and let the birth move ahead. And then after we've done the breathing behavior analysis and they've learned how to come back into a really beautiful baseline, regardless of what they're doing, they have these easy, soft births that say, I didn't know it could feel that way. It just felt like a workout at the gym. Stretching is fun. So if we can create some new metaphor, Peter, around what the sensations of birth are feeling like, it's not, can we figure out ways to breathe so that it doesn't hurt as much? Instead, it's, can we allow ourselves to breathe in the way that maximizes the muscle's potential to accommodate the descent of the baby? Can we let that uterus move? Can we let the perineum stretch with good oxygen delivery during the stretch? The stretch on its own is an indicator to the body, that's the place we need the most oxygen right now. And if we're over breathing during labor, we have tight perineums. We have a cervix that's having a hard time opening because it's not getting proper blood supply. We have placentas that don't adhere properly. They might come off too soon. Why?
Yeah, overventilating will produce constriction, muscle constriction. I mean,
Exactly.
it's a
these are
vasoconstrictor. Everything constricts. So when you try to reach for more air, and too much air, and you lose carbon dioxide, constriction occurs everywhere. And one thing I'd like to mention to everybody out there on YouTube or wherever they're going to be, wherever they are going to be, is that, you know, the school, the Professional School of Behavioral Health Sciences, which is a sponsor of this nonprofit as well, we have programs in certification programs in capital learning, and one of them specializes in pregnancy. Yes. They're all the same certification program, but they have different emphases. So Lisa teaches the one that emphasizes pregnancy. So if you have an interest in that kind of thing, you might want to go to the professional school's website at B as in Bravo, P as in Papa, bp.edu. bp.edu. We're a licensed higher educational institution. So you can get professional CE credit, academic credit, whatever you want. And our programs are also accredited in the EU and the Commonwealth countries and so on. But anyway, if you're interested in that, getting education in breathing behavior analysis and specifically pregnancy, just go to the website and you can look that up. There are programs that start in the fall, I think September 26 or September 27, something like that. But anyway, there are some people here I think may have some questions because I see a lot of comments coming in, so maybe we can answer a couple of questions.
Before we go there, Peter, can you repeat the website for the school for those who are interested? Yeah,
B as in Bravo, B, P as in Peter, BP like in breathing physiology, BP dot edu. So in any event, let's see if we take a couple of questions here. So we have Kate Kusch. Do you want to bring someone to us?
Yes, Peter.
Yeah, there's some people with a question, like Desi has a question, I think. Do you want to bring her on so she can ask a question?
Yeah.
Hi.
Hi.
Thank you. Before I ask my question, I just want to say how grateful I am to be here in this podcast that I saw. I got the email. I wasn't planning to attend this meeting today. It was like a coincidence. I saw the invite and I said, okay, let's see if I'm on. I didn't even check the time, but I'm so grateful I did because it's a privilege to be and listen to the professionals in the medical field talking about breathing. I like to say that I'm an instructor, functional breathing instructor from Oxygen Advantage. I don't know if you have heard of that school. Yes. And I'm so happy to be here and to find out that you guys do this type of work podcast and listening to Dr. Lisa and to yourself. I mean, this great information. It's thank you so much for doing this.
Very, very welcome.
Yeah. I'm not a doctor. I know, I mean, I understand everything you're talking. Of course, I'm not a doctor. I'm not in the medical field, even though I think breathing is a big, huge gap in the medical field. Like that, and they don't talk about breathing, and it's so important. And hearing you saying the importance of, breathing and respiration is like, I knew it. So it's beautiful. Thank you. When Dr. Lisa started talking about tonsil removal, I was thinking I'm gonna ask because I know an 18 years old girl that she got her tonsils removed when she was a child, probably 8 years old, and she has breathing problems now. She suffers of anxiety. She can inhale like deeply. And I know that when you get your tonsils removed, you suffer, your airways stay probably in that habit that you were talking about before. So I just wanted to hear you guys' perspective about, but the consequences of removing the tonsils in a kid and breathing. And thank you again.
Thank you. Lisa, you want to comment on that?
Sure. One of the first things that I work with when I have a client, and often younger people who have come in with a history of tonsil issues and sinus issues, is talk to them a little bit about why is that happening in the first place? Why do we have this swollen tonsils and these sinuses that just never seem to stop producing mucus? And reminding them that that is the first disordered breathing piece that we have to work with, is that we get into a vicious cycle. When we're young, we have a common cold. And if we feel too stuffed up to breathe through our nose, we might start breathing through our mouth. And then as we continue to breathe through our mouth, our sinuses are overactivated to try to build themselves up and hang down the back of our throat so that it can warm the air, moisturize the air, and clean the air that's supposed to be going through your nose most of the time, right? It's not that mouth breathing is terrible and you should never do it. You can get great chemistry, breathing chemistry, mouth breathing, but there are other consequences to prolonged mouth breathing. So now we have children who have an infection, everything is swollen and big because there's body parts that are doing the job of the sinuses. So then when they have those removed, but they continue to breathe like they were when they were having the congestion, they actually perpetuate more congestion. So the nasal cavities never really get to settle down. We have a hyperactive system in the airways. It's hyper aroused because it's not getting what it's built to expect. So when we work with children and adults in this to break that cycle, the first thing is to choose differently. And for most of the people that I work with, even with just 2 weeks of consciously attempting to breathe softer through the nose, they notice a difference in their airway. Ironically, what they notice first is they feel like they're getting a cold because everything gets runny and they start to have a lot of mucus. And that's actually the airway correcting itself. So they think they're getting sick, but it's actually progress. And that's where we have to break the vicious cycle, is right there, and just say, look, you can breathe through your nose when it's stuffy. Here's how. And we start to look at what are options, different breathing habits for the symptoms that are presenting to break the cycle, putting a wedge into the cycle. Now they actually also have cognitive ability to look at the problem from a different point of view. And as we do that, the airway can heal and start functioning the way it's supposed to be. And then they can relearn how to breathe with a normal airway instead of one that their body's constantly responding as obstructed in some way. Does that answer your question, Des?
You're muted, Desi. So we have to unmute you. Oh, his thumbs up. Also when you have an experience.
Thank you so much. You completely answered my question. And please let me say this. I see you talking about breathing with that passion, and I feel like I'm in the right place. Like I made the right decision. You know, I'm a beginner. I've been in this field for about a year, but I'm loving it, and I want to keep, you know, growing and learning, and I'm glad I'm seeing two people like you, specialists in the medical field, with that passion about breathing. Thank you so much.
Really
Thank
great
Thank you.
to have you here.
Because it makes
You are
all the
in the
difference
right
having
place.
people like you here, you know.
Yeah. Yeah.
So I think that's probably it for today. Just to let you know, I think it's July 24th, is Friday, same time, 10. We're going to have someone who had long COVID and suffered a great deal, but worked through it by going through a breathing behavior analysis, and now is in a very different place. So we'll hear about that in July. So thank you very much, and we'll see all of you again. And of course, all the people who watch the recordings, we invite you to come in and be with us live. You don't need to just watch the recordings.
That's
We'd
right.
love to see you in person.
And if people
So,
are interested in the online courses through the school with the Capno Learning, as Peter mentioned, I am doing the teaching for the one that's specifically for breathing for birth professionals. And if you're not sure that that's what you want to do, there's also another couple of podcasts out there where you can see me talking about pregnancy through the American Association of Pre- and Perinatal Health. And that all of that, I'm working with them in conjunction to bring people into the Capno Learning program so that we can introduce the ideas of normal respiration to mothers and newborns, and then watch how that changes the culture around what it means to be human and how we feel and how we process pain. Because when we can teach moms and babies, we change our culture. So I'm working at it from that end, as well as in my private clinic and working at Sleep and Brain. So if you want to reach out, if you have any other questions, you can also reach me through the school at LVK at it's bp.edu, right, Peter?
right, bp.edu.
Yep.
LVK at bp.edu.
Yes.
Mhm.
And I look forward to answering your questions.
So
Thanks,
thank
Peter,
you,
for having me.
and we'll see you again. And so, Keikashaw, if you can